Good morning. Thank you for joining us this morning. My name is Raina. I'm the program director at Total Health. And welcome to the 2025 Best of Breast Conference. We're so excited to have you all here. I'm just going to go into a little bit of background about the meeting, some housekeeping, and then we will get started. So with us today, we have a few people in person with us, joining us, but this meeting is hybrid. So we have over 400 attendees joining us virtually. So we want to say thank you to them for joining us, and we're excited to have them. Our program chairs for today are Dr. Reshma Mahtani from Miami Cancer Institute and Dr. Neil Iyengar from Memorial Sloan Kettering Cancer Center. They're right up here in the front, and as you see them walking around today, you can say hi as well. And they'll be moderating the cases as we go throughout the day and the presentations. Some few housekeeping stuff. In front of you, you're going to see a program guide. In the program guide, you will see a little insert that has the most up-to-date agenda on it. There's just a few time updates, speaker updates, so you'll see that inserted into the program guide. On some other pages, you'll see how to claim your CME and mock points. You'll see non-CME session information, agenda, Wi-Fi information, and how to download the app. And so I do encourage all of you to download the app. If you go to your app store and search CVent Events, you'll download that. And then once you download the CVent Events app, you'll search 2025 Best of Breast. That'll allow you to interact with the virtual audience. You'll see their questions coming through. You'll see PDF slides. And it's a great opportunity to interact with those virtual audience. And to the virtual audience, as you're in the platform watching the sessions, you can be sure to add your questions into the Q&A tab on the side of your screen, and we'll try and get to your questions as we're going through the cases today. If you also are in person, we're doing a bingo raffle today. So if you didn't pick one up at the registration desk, there's a bingo sheet. It has the exhibitor logos on them. So if you take that, you can go into the exhibit room, get it initialed by each company, and then hand it in to the registration desk, and we'll call out a winner at the end of today. Yes. And then also something fun we're doing, as you walked into the general session room, you might have seen a sign that says, "What's your favorite TV show?" And a little iPhone set up on a tripod. So it's something fun we're doing on social just to, make people laugh and get some interaction. So if you want to participate, you'll see different questions throughout different breaks. And it's just something fun to hear everyone's thoughts and something good to participate in. So I encourage you all to do that as well. Okay, let's get started. I'm going to introduce Dr. Reshma Mahtani to the podium, and she will kick off our first case with our first couple of speakers. Thank you.
Good morning, everyone. Thank you for joining us here in person, and for those of you who are attending virtually, thank you as well. It's great to be back here at the Best of Breast meeting. We took a bit of a hiatus last year, and now we're back, and this is a unique format. You'll see that we have the day set up in terms of case panel discussions, and our first one is an early stage ER-positive, HER2-negative case. I'd like to start by inviting our panelists to join. We have Dr. Taiwo Adesoye from MD Anderson Cancer Center, Dr. Joseph Panoff from Miami Cancer Institute, and Dr. Naomi Dempsey from Miami Cancer Institute as well. So you see our specialties here on this first intro slide. Thank you all for joining us. So the format of the case discussion is that we've engineered a case, and we'll talk about the management from a multidisciplinary standpoint. We have about an hour for this panel. There's no formal question and answer session, but I do think, and Raina, correct me if I'm wrong, but we have the opportunity to ask questions here live as well as virtually, and I suppose you'll be fielding the virtual questions, and speak up and let us know if someone has a virtual question that I'll repeat for everybody. We want to make it an interactive session, but we want to have some guardrails around the discussion, so we have some discussion points built into the case presentation. So let's get started. We will start with the patient history. This is a 45-year-old premenopausal woman. She has a known germline BRCA2 mutation, and she undergoes annual MRI and mammographic surveillance based on this germline mutation. Her family history, as expected, is notable. Her mother had breast cancer at age 50. She has several first cousins with breast cancer. And she undergoes a diagnostic mammogram that identifies a left breast mass, 1.9 centimeters, and there are no suspicious lymph nodes on mammogram or on physical exam. But on breast MRI, there is an enhancing irregular left breast mass that's highly suspicious for malignancy, and an indeterminate left level 1 axillary lymph node that's described as slightly enlarged. So we don't have a radiologist here, but I think it's pretty easy to see the mass here by mammogram and also by MRI in the left breast. Her biopsy reveals invasive ductal carcinoma that's high grade, grade 3, ER positive, 90%, PR 60%, HER2 1+ by immunohistochemistry with a Ki67 of 15%. The axillary lymph node is also biopsied and reveals invasive ductal carcinoma. She undergoes surgery up front, and you see the pathology here. In the right breast, there are no abnormal findings, but in the left breast, there is a 2.1 centimeter invasive ductal carcinoma with clear margins of resection, no evidence of lymphovascular invasion, and there is 1 out of 9 axillary lymph nodes that are positive for carcinoma, 6 millimeters in greatest dimension with no extranodal extension. She does undergo a genomic assay, a 21 gene recurrence score, and it comes out at 20. So here are some of the management questions that we'll be going through today, and the first one is really with regards to the approach that was taken. This patient didn't have neoadjuvant therapy. She went through surgery up front. And I will start by asking Dr. Adesoye to take us through the discussion from a surgical perspective.
Can you hear me? Okay, perfect. So first of all, I want to start with some principles of surgical management in breast cancer. And the thing we know is that surgical management is dependent on tumor subtypes. So whether it's hormone receptor positive, as in this case, whether it's triple negative breast cancer or HER2 positive breast cancer, it also depends on the T stage, so how big is the tumor, and then nodal status, are the lymph nodes involved? And over time, there's plenty of evidence to support the fact that the extent of surgical therapy does not alter tumor biology or improve survival outcomes. It's more for local regional control, for staging. And because of this evidence, over the years, surgical management has evolved to reduce morbidity. And we take the approach of right-sizing surgical management both in the breast and in the axilla. And de-escalation of surgical therapy can be facilitated by effective neoadjuvant systemic therapy. So for triple-negative breast cancer or HER2, except the small and node-negative diseases, we will often recommend neoadjuvant systemic therapy, and also for local regionally advanced hormone receptor-positive disease. So some key questions I ask when I'm evaluating a patient for surgery, I want to understand the biomarkers, the subtype as I discussed, the extent of disease. Like I said, all of this will inform upfront surgery approach versus neoadjuvant systemic therapy. And then in terms of the actual surgical approach from the breast standpoint, we have the option of breast conserving therapy, where we're doing a lumpectomy combined with radiation therapy or a mastectomy. And it depends on the tumor size, it depends on the patient preference, it depends on their genetic status, like in this patient who has a BRCA2 mutation. And then from the axillary standpoint, I'm thinking, is this patient a candidate for omission of surgical axillary staging? Or does this patient, are they a candidate for sentinel lymph node biopsy, targeted axillary dissection, which is selective excision of the clipped biopsy-proven node combined with a sentinel lymph node biopsy? Or is this patient going to require an axillary lymph node dissection? So there are benefits to the neoadjuvant systemic therapy approach, where you're giving treatment first prior to surgery, And there's also benefits to upfront surgery. So the benefit for giving neoadjuvant systemic therapy first is that we have an in vivo assessment of tumor response, and we know that this is prognostic. It gives us information about how well the patient is going to do in the long term. It also allows us to downstage disease, so I can, decrease the surgery I'm doing in the breast and in the axilla, and also we can de-escalate axillary radiation, as you'll hear about soon. And the identification of residual disease after systemic therapy informs our adjuvant treatment. And it's typically reserved for those tumors that I listed there, some T3, larger node positive, HER2 triple negative, and largely locally advanced hormone receptor positive disease. Now, the upfront surgery setting does have the advantage that you get accurate pathologic staging, and that also helps avoid overtreatment. And this is primarily the approach for early stage node negative hormone receptor positive disease. So in terms of management of hormone receptor positive cancer, like I mentioned, just like the other breast cancers, it's determined by T-stage and nodal status. For early stage node negative disease, upfront surgery is usually the approach. For patients with advanced disease, we will do neoadjuvant systemic therapy. But patients that are early stage node positive, these are a unique group, and their approach to treating these patients is complex and evolving. And that's really because historically they've had poor response to neoadjuvant therapies. And that's really limited the benefit of breast and axillary downstaging. So you don't just give systemic therapy to these patients because you want to downstage the surgery that you want to downstage disease in the breast and the axilla so you can de-escalate surgery. It's not very effective in this patient population. So if you didn't hear me say it the first time, it is complex and evolving. And another reason is because these patients have historically been excluded from clinical trials that were supporting de-escalation of axillary surgery in the upfront surgery setting. And that was because back then, neoadjuvant chemotherapy was the standard of care in this patient population. But we know that 40 to 60% of patients with CN1 disease will only have PN1 disease. So on pathology, they're only going to have anywhere from 1 to 3 positive nodes. And we know that T-stage is predictive of higher nodal burden. So the bigger the tumor size, the more likely they have to have more lymph nodes involved. There's been a lot of interest in de-escalating axillary surgery in this patient population to avoid the morbidity of axillary lymph node dissection. And there is a trial called the TAXIS trial that's looking at tailored axillary surgery, which is selective removal of lymph nodes, not the full axillary lymph node dissection, combining that with regional nodal irradiation and comparing it to axillary lymph node dissection in this patient population. So there are some other opportunities or choices for systemic therapy that we have, and so neoadjuvant endocrine therapy is one of these. And there are studies that have looked at the efficacy of neoadjuvant endocrine therapy in this patient population. And very much like neoadjuvant chemotherapy, we don't have exciting results, and so it hasn't uniformly taken off amongst the medical community. And we usually reserve neoadjuvant endocrine therapy for patients who are poor surgical candidates. We will use it as a delay strategy, as we did during COVID. And we will use it to facilitate lumpectomy because there's a trial that showed that these patients who receive neoadjuvant endocrine therapy can often go from a planned mastectomy to a lumpectomy. However, we don't see the same impact on the nodes. The nodal PCR rates are pretty low, anywhere from 1 to 13%. So certainly more data is needed in terms of axillary surgery for this patient population receiving neoadjuvant endocrine therapy. So my thought is, in terms of managing these patients, particularly from the axillary standpoint, it is reasonable to consider upfront surgery with targeted axillary dissection, where you're localizing the biopsy-proven lymph node for excision, in addition to a sentinel lymph node biopsy in patients with limited nodal burden. And that is where an axillary ultrasound will be really helpful to help determine the nodal burden in these patients.
So thank you for taking us through that decision making. Before we move on to the next management question, I am curious about your approach in patients that have a known germline mutation in terms of the timing of the contralateral prophylactic mastectomy. We know patients who go through bilateral mastectomies up front have greater risks associated with healing and just postoperative complications that can occur. Do you do that in a staged setting, or would you recommend upfront in this patient?
So it really is shared decision-making discussion with the patient. For patients with early-stage disease and who just have node-positive disease, I'm very comfortable doing the contralateral prophylactic mastectomy at the same time as I'm doing the index breast. And my thought is, and this is what I tell the patient, our primary concern with, when we say we want to delay the surgery in the contralateral breast is because we don't want any issues with surgical complications delaying therapy. So, of course, things like systemic therapy, things like radiation therapy. But in this patient population, they don't always need the systemic therapy. They do need the radiation therapy, but this is where the patient preference also comes in. I tell them, these are the rates of complications, which have gotten much better over time, and we make that decision together. But if it's someone with very advanced disease that we want to get them on systemic therapy right away, we want to avoid any sort of delay due to complications, I will tell them to reserve the contralateral prophylactic mastectomy until after they've received treatment for the index cancer.
Certainly these decisions are complex. So let's move on to the medical oncology aspects to this case and address these questions. Is there a role for genomic assays in premenopausal women with node-positive disease? And what would your systemic therapy recommendations be? And Dr. Dempsey, I'll also add another question that I don't think you've addressed in your slides, but just in terms of the assays as far as the possibility of using intrinsic subtyping on some of these other assays like Blueprint or PAM50. Do you see a role for those in identifying a possible strategy for these patients? So I'll let you take us through your slides.
So the treatment of early stage hormone receptor positive HER2 negative breast cancer from the systemic standpoint really is also evolving, and we're really looking to personalize therapy to de-escalate where we're able to, but also identify those patients that we know are at high risk of recurrence and add additional therapies where they're needed. So endocrine therapy is certainly the cornerstone of systemic therapy for these patients, and it's been long understood that aromatase inhibitors are superior to tamoxifen for prevention of recurrence. But there's some additional therapies that we think about in this setting. We'll talk about ovarian suppression for high-risk premenopausal women. We'll talk about the addition of CDK4/6 inhibitors in the adjuvant setting. We'll discuss chemotherapy and which patients are going to be the best candidates for chemotherapy, understanding that not all patients with early-stage hormone receptor-positive HER2-negative breast cancer are going to benefit from chemotherapy, and really needing to be precise about who are the patients that benefit so that we don't have unnecessary toxicity in patients that aren't going to benefit from that therapy. When we look at the NCCN guidelines for the use of genomic assays in this setting, we see that the Oncotype DX 21 gene recurrence score receives the preferred status from NCCN, and that's because this assay has been shown to not only be prognostic, but also to be predictive. It has a level 1 category of evidence, both in node negative and in 1 to 3 positive node postmenopausal patients, but a 2A category of evidence for our premenopausal node positive patients, and we'll discuss a little why that is. The MammaPrint assay can also be used in this scenario and has a level 1 category of evidence, however, has only been shown to be prognostic but not predictive, which is why it's not listed as a preferred option in NCCN. So as we start to think about this patient that we are now trying to decide, does she need adjuvant chemotherapy after her surgery? We'll look at the data from the RxBonder trial that helps us to start to answer that question. The RxBonder trial looked at women who had ER or PR positive breast cancer, HER2 negative, with 1 to 3 positive lymph nodes and no distant metastasis who were eligible to receive chemotherapy. And patients who, everybody received a recurrent score, and then anyone who had a recurrent score of 0 to 25 was randomized to either chemotherapy followed by endocrine therapy or endocrine therapy alone. And this did include both premenopausal and postmenopausal patients, which was one of the stratification factors, as well as the range of the recurrent score and which axillary surgery they received. And so looking at the primary endpoint of 5-year invasive disease-free survival, we saw that postmenopausal patients with 1 to 3 positive lymph nodes with a recurrent score of 0 to 25 did not have a difference in their invasive disease-free survival with versus without chemotherapy. However, in our premenopausal patients, we saw that there was an invasive disease-free survival benefit with the addition of chemotherapy, and this was regardless of the level of their recurrent score, both those with a low recurrent score of 0 to 13 as well as those with a higher recurrent score of 14 to 25 had similar benefits with the addition of chemotherapy, with hazard ratios of 0.46 in the recurrent score 0 to 13, and a hazard ratio of 0.57 in the recurrent score of 14 to 25. And so in some ways, this actually raised more questions for us than answers. This has led us to really wonder if the benefit of chemotherapy in these patients is a direct cytotoxic effect versus the effect of ovarian suppression, which obviously we can achieve in a much less toxic way than using cytotoxic chemotherapy. It's important to note in this trial that these premenopausal women with lymph node positive disease mainly received single agent tamoxifen as their endocrine therapy. And we're going to talk a little in a moment about the soft and text trials. But it seems that probably many of those women should have received ovarian function suppression. And there are some additional trials in this space, such as MIND-ACT and TAILOR-X, that look at premenopausal women amongst their overall cohort. And we see fairly consistent benefit as well in TAILOR-RX, which was node-negative patients, and those that had a recurrent score of 16 to 20 with high clinical risk, or those with a recurrent score of 21 to 25 benefited from addition of chemotherapy. Premenopausal women in MIND-ACT using MammaPrint benefited from the use of chemotherapy. And so we're again really questioning what exactly is that benefit of the chemotherapy. And so I think the soft and text trials provide some useful information for thinking about ovarian function suppression. The soft trial evaluated premenopausal women with early stage hormone receptor positive HER2 negative breast cancer and compared different endocrine therapy options, tamoxifen alone versus ovarian suppression with tamoxifen versus ovarian suppression with AI. And we now have long-term follow-up from these trials. We saw that the 12-year disease-free survival was better with ovarian function suppression plus endocrine therapy versus tamoxifen alone, and that overall survival was also improved. And so then when we look at the combined analysis of soft and text, which really seeks to answer the question of ovarian suppression plus AI versus ovarian suppression plus tamoxifen, we do see, again, a disease-free survival benefit and distant recurrence-free interval benefit from the use of AI with ovarian function suppression versus tamoxifen with ovarian function suppression, but did not see a significant overall survival benefit in the overall cohort. And so the authors did some subset analysis to understand a little better who are the patients who really benefit from this combination of ovarian function suppression and AI, and ultimately found that women that were younger than 35, women who had a tumor over 2 centimeters, and women who had a grade 3 tumor had significant overall survival benefits with the use of ovarian function suppression plus AI. There wasn't a significant difference between different lymph node groups in that analysis, but I think many of us feel that lymph node positive patients should also receive ovarian function suppression. And so, again, when we put all this data together, we're left with questions about what is really the optimal management for our premenopausal patients, and is there an opportunity to de-escalate therapy? Do they all need chemotherapy? And the OFFSET trial, which is an NRG study, is looking to answer this question. It is enrolling premenopausal patients with hormone receptor positive, HER2 negative breast cancer. Anybody with pathologic N1 can be enrolled with a recurrence score of 0 to 25. And then for so basically our RX-responder patients, and then the Taylor-X patients that are node negative with either a recurrence score of 21 to 25, or if they have a recurrence score of 16 to 20 and high clinical risk, they are eligible. And high clinical risk is defined as either a grade 3 tumor that's over 1 centimeter, a grade 2 tumor that's over 2 centimeters, or a grade 1 tumor that's over 3 centimeters. So basically taking all of the patients that we've been left with these questions about and stratifying according to nodal status, according to the level of their recurrence score, and then randomizing to either chemotherapy with ovarian function suppression and AI for 5 years versus ovarian function suppression and AI for 5 years. And so hopefully this will help us to answer these questions about whether these women really are getting a direct cytotoxic benefit from chemotherapy versus just an ovarian function suppression benefit from chemotherapy. So then as we think further on to the adjuvant setting and identifying those patients who are at high risk of recurrence, we're now in an era of using adjuvant CDK4/6 inhibitors. And the first trial to give us data related to this was the monarchE trial. This was a phase 3 trial that evaluated patients with high-risk node-positive, HR-positive, HER2-negative early breast cancer. And patients were candidates if they either had 4 or more positive lymph nodes, or if they had 1 to 3 positive lymph nodes with either a tumor greater than or equal to 5 centimeters, or histologic grade 3. And an additional cohort was added looking at the contribution of Ki-67 in patients with 1 to 3 positive lymph nodes, and no other factors that would have qualified them for cohort 1. Patients were randomized to either abemaciclib, 150 milligrams twice daily for 2 years, plus endocrine therapy, versus endocrine therapy alone. And we now have longer follow-up data from this trial, keeping in mind that it's a 2-year treatment course, and as we look beyond that time of treatment, we only see the difference in these 2 treatments, in these 2 curves continuing to separate, now with a 7.6% difference in 5-year invasive disease-free survival between the 2 treatment arms, which has really established this therapy as a standard of care in patients who qualify. There is not yet a statistically significant overall survival benefit, but when we look at the number of patients who are living with metastatic breast cancer, in follow-up from monarchy, we see a larger number of women living with metastatic breast cancer in the endocrine therapy arm versus in the abemaciclib arm. And so the next trial to look at adjuvant CDK4/6 inhibitors is the NATALEE trial. This is a phase 3 trial that evaluated, again, patients with hormone receptor positive, HER2 negative early breast cancer. And this was a slightly more expanded cohort, which also included some patients who were node negative. They had to either have grade 2 disease or a Ki-67 greater than or equal to 20%, or a high-risk genomic assay. They could be node negative with grade 3 histologic status or N1 disease. Stage 3 disease was also allowed. And so in a moment here, we'll show you a table that puts that really clearly. So patients were randomized to ribociclib at 400 milligrams daily, 3 weeks on, 1 week off, which is a lower dose than our metastatic dose, in combination with nonsteroidal aromatase inhibitor for greater than or equal to 5 years versus nonsteroidal aromatase inhibitor alone. Men and premenopausal women also received goserelin, and it's important to note that there is a drug-drug interaction between tamoxifen and ribociclib, so patients were not able to be on tamoxifen in combination with ribociclib. And so the ribociclib course is a 3-year treatment, and we now have data, follow-up data from 4-year invasive disease-free survival, again, continuing to see an increase in the difference between the curves with time off therapy, similar to the kind of trend we see in monarchy, which is really important to just note that these treatments aren't just delaying recurrences, they really seem to be preventing recurrences. So I think this chart is kind of just helpful to have in the clinic for when you're trying to determine whether your patient is a candidate for either of these options. I would make note that monarchy did allow patients with N1 microscopic disease, so they could have had micrometastatic nodal disease and still be considered, whereas in the NATALEE trial, micrometastatic disease was not allowed as an eligibility factor for node positive.
So before you go on to the next slide, I'll just point out that the patient that we are discussing is eligible for both.
She's eligible for both.
And what would your approach be? How do you make the decision?
So in general, anybody who's eligible for both, I am tending to use abemaciclib just because we have longer follow-up data. We don't have yet a statistically significant overall survival benefit, but I think the fact that we see more patients that are living with metastatic cancer on the endocrine therapy alone arm versus the combination arm is a compelling reason to use the abemaciclib. And perhaps over time, when we've got longer follow-up data from the NATALEE trial, we'll be in a tougher spot to make those decisions between the two, but for now I'm leaning towards abemaciclib. And then if they don't qualify for abemaciclib but do qualify for ribociclib, or if they're having too much toxicity with abemaciclib and needing a switch, then I'll use ribociclib.
So I'll push back a little bit and just be devil's advocate here. We're always going to have longer follow-up, right, with abema. That's just the way it's going to inevitably be because of the timing of the trials. So in terms of decisions for individual patients as far as the toxicity profile, the dosing, do you see an opportunity to individualize even in patients that are node positive?
I tend to find that with abemaciclib, with the dose reductions and with dose holds as needed, we're really able to make this therapy tolerable. And we've seen data looking at dose reductions both for ribociclib and for abemaciclib in the adjuvant setting, and we don't see that there's any impact on the benefit with dose reduction. So I think we should feel really comfortable to dose reduce when we need to and to reassure patients this isn't going to affect your outcome, because that's something patients are really worried about.
Really important points.
So would she be eligible for adjuvant PARP inhibitor therapy given that she's germline BRCA2 positive? So the Olympia trial looked at patients with germline BRCA1 and BRCA2 mutations, and these patients could either be hormone receptor positive, HER2 negative, or triple negative breast cancer, stage 2 to 3 breast cancer. And so thinking about our patient in the adjuvant group, for those that were ER and PR positive, they had to have at least 4 positive lymph nodes to qualify for Olympia. And then patients were randomized to 1 year of olaparib, 300 milligrams twice daily versus placebo. And next slide. And we saw that there is an invasive disease-free survival benefit for the entire cohort with the use of adjuvant olaparib. We got new data from this trial at SABCS 2024 that's now 6-year follow-up data showing a 6-year invasive disease-free survival benefit of 9.4%, very impressive. And when we look separated out by hormone receptor status, we see that there is benefit both in the triple negative group as well as in the hormone receptor positive group. And we now also have a statistically significant overall survival benefit with the use of adjuvant olaparib in these patients, which is exciting to see.
So the patient population that was enrolled that had surgery up front and were ER positive had a really high risk disease profile with 4 or more positive nodes. Are you sticking to that exact criteria? How comfortable are you in changing what you do in clinical practice? Say she came in and said, oh, I heard about this trial and it showed a survival benefit, I want the PARP inhibitor. How would you approach that?
I think it's certainly a discussion. I'm not sure if there'd be issues getting insurance to approve it, but I'm kind of willing to work with patients and talk about the data and talk about the potential toxicities. I guess in this setting, I think that the fact, which we'll be talking about here, that we can't combine adjuvant PARP and abemaciclib. There's no safety data for that combination, and there is overlapping toxicity with cytopenias, and with a kind of a known benefit from the abemaciclib, whereas in her specific situation, we don't
Correct.
know that there's benefit from PARP inhibitor. I would really be looking to prioritize the 2 years of abemaciclib.
Yeah,
and
I
if she
agree.
still wanted to talk about adjuvant PARP at the end of the 2 years, we can talk about it, but I think we'd be kind of in a data-free zone.
I agree. I think in a really high-risk patient population who had that 4 or more positive nodes, you might consider sequencing them, and in that case, I would probably prioritize the PARP,
Exactly.
given the survival benefit.
Yep, agree.
So this is interesting data that you can maybe take us through.
So this was a trial looking at patients with metastatic hormone receptor positive breast cancer who also had germline BRCA mutations. And it compared first-line CDK4/6 in patients who had BRCA wild type versus pathogenic variants, and we see significantly worse progression-free survival using first-line CDK4/6 inhibitors with the patients who have germline BRCA variants. And so I think this also raises kind of that interest in thinking about how effective are the CDK4/6 inhibitors in patients with germline BRCA variants, and I think that's why if she were a candidate for both, if she had the 4 positive lymph nodes, again, with this data, with the survival benefit in the Olympia trial, I would look to do the year of olaparib first and the 2 years of abema afterwards.
Of course, these are small data sets, right? There were 100 patients, I think, that had BRCA2 mutations, 120 that had BRCA1, but still very provocative and interesting. So last but not least, let's talk about the role for post-mastectomy radiation.
Right, okay, so what I tell patients, the first thing that I tell patients is with N1 disease, and the type of surgery is obviously really important, but and we have also, I'm going to present trials that show that we actually, for this specific patient, we have a definitive answer on what to do. But for other scenarios of N1 disease, it's the Wild West. And I tell people that if you were to go to 100 places all over the country, you'd get 100 different types of treatment. And so, but the basic model or treatment schema is either upfront surgery, neoadjuvant chemotherapy, and then the type of surgery, either lumpectomy or mastectomy, and then radiation is always going to be adjuvant, although there are now preoperative radiation trials, a lot of them ongoing. And then we have to decide kind of what type and what of radiation to give and what technique. You can go to that, yeah. And so there have been meta-analyses in the 1 to 3 positive lymph node spaces that have showed benefit with post-mastectomy radiation, or in the breast conservation setting, breast and regional lymph node radiation. 4 or more nodes, we already know, we have very good data that there's a benefit. However, the issue and the controversy is that the meta-analysis were performed on trials that used older systemic therapy. And so the thinking is, well, with modern systemic therapy, is there still a benefit of radiation in the 1 to 3 lymph node space? And really the trend, which I'm going to show, is de-escalation of radiation. And it's an overall trend. And so the first trial, which this patient fits into except for the BRCA mutation, but I wouldn't change my management because of that. This was just presented at San Antonio Breast in December. And so it was really a landmark practice-changing trial called Supremo. And we, as radiation oncologists, consider this type of patient that was presented as, it's called intermediate risk. So N1 disease is intermediate risk. We think of early stage or early risk breast cancer as N0 disease. And so what this trial included was T1, T2, N1 patients. So that would include this patient because this was a T1, N1 patient. Patients were eligible if they were T3, N0, but very few were actually enrolled into the trial. And then there was another cohort that was T2, N0 if they had grade 3 or lymphovascular invasion. And so this table shows the amount of patients with the nodes. And so actually 3 lymph nodes, it was N1 disease, so 3 lymph nodes were included, but there were relatively few patients with 3 nodes, so I wouldn't make decisions for that group. But the 1 lymph node and 2 were well represented in the trial, and one caveat is they had ALND and they had to have a minimum of 8 nodes, which this patient did. And so if you go, so these patients were randomized to either chest wall radiation alone, so they actually didn't treat the lymph nodes in any arm, or no radiation, okay? And this is a European trial. It was UK, and they just don't, people do have different radiation protocols with the regional lymphatics, and so they didn't treat the lymph nodes at all. So it was just chest wall versus no radiation. What they found is that there was no benefit for post-mastectomy radiation in this group with regard to overall survival. The recurrence, that chest wall recurrence, there was a difference, but it was a 2% benefit. So it was considered clinically insignificant. And and the regional disease was also considered clinically insignificant because the numbers were so low. And so the conclusion of this trial was that these patients do not benefit from post-mastectomy radiation. And so for this patient, even though, again, she wouldn't be included because of the BRCA mutation, I would not offer her radiation. And we see a lot of these people, and so I wouldn't treat her. Now, the other thing that makes it a little bit more confusing with this is just that she's still eligible for another trial, which I'm going to highlight. And so now we don't know what to do with these patients. And so this is also showing the targets that we treat, because when we talk about regional radiation for lymphatics, there's a lot of potential toxicity, and that's because we're treating the axilla, we're treating the supraclavicular fossa, and then we also, many people will treat the internal mammary lymph node chain, which is very close to the heart. And so it's not without potential short-term toxicity and long-term complications, and so we have to be very careful what we do. And again, this was the meta-analysis that showed that benefit in the N1 arm, which we had talked about, was older systemic therapy. If you go to the next one. I'll keep going to the next slide. Right, and so there are trials that show that inner quadrant tumors benefit from treating the IMC, not from overall survival, but from local control. And so this led to many people changing their practice to include the IMCs in their nodal volumes. That it's a very controversial area still in our field. I always include the IMC when I treat regional nodal radiation. The next trial that I'm going to touch on mandates it. Most of the trials mandate that. And so, but there's places that don't. It also depends on what technology you have. So if it's a left-sided case and you're going to include the IMCs and you have proton therapy, then you don't really have to worry as much about the heart than if you don't have that technology. So I think if you were to look at people's practice, the technology they have is going to guide the regional nodal treatment that they do. So in the upfront neoadjuvant chemo setting, it's a little different, but the trend is also de-escalation. And so this trial, NSABP-B51, was another landmark trial. They reported results at the San Antonio Breast Conference from 2023, although they have not published their results yet, but it still changed practice, and many people all over the country have changed practice because of this. And so what this trial was, a large trial, they had 1,500 patients, and it was either, so it was T1 to T3, N1 disease, and you had to have a biopsy-proven axillary node, and the patients all had neoadjuvant chemotherapy, and then they were randomized so for people that had they had to have a pathological complete response in the lymph nodes, okay, after surgery. And so this included breast conservation and post-mastectomy patients and mastectomy patients. And they were randomized 1-to-1 to either no regional radiation or regional radiation. And so for mastectomy patients, it meant no radiation at all versus comprehensive, including the IMNs, okay? For breast conservation, it meant breast alone versus breast and nodes. And so this was a big question that we needed to have answered. And what they found was that there was no difference. Again, radiation to the lymphatics added no benefit. And this was a 5-year out, so we don't have 10-year data. The Supremo trial is 10 years. This is 5. So at 5 years, there was no difference. And they had very high survival rates. They included all different molecular subtypes. However, this patient that we discussed was not neoadjuvant chemotherapy, but the ER-positive, HER2-negative patients were underrepresented, obviously, because they have lower rates of pathological complete response in the lymphatics. And by the way, the primary pathological complete response did not matter. So if they didn't have a complete response in the primary, they're still eligible as long as the node responded. So this was practice changing. And now many people, I think some people still do this case by case because they've not published their data, and it is also 5-year data. But this has led to people, radiation oncologists, not offering these folks radiation. So this is another group that we do not treat now, which is great. Next slide. Okay, so so this is now an ongoing de-escalation trial, which is international. Taylor RT, similar to Taylor RX, we want to have this decision-making, oncotype decision-making tool. And so the patient we talked about today would fit into this. But again, now that we have the Supremo results, I think many people are not offering the patient the trial. I wouldn't offer the patient this trial now at this point because of the Supremo. So it's kind of case by case. But eligibility for this is oncotype of 25 or less, which is similar to TAILOR-RX. And these people are T1, T2, N1 disease, 1 to 3 positive lymph nodes. And it's also either breast conservation or mastectomy. And so these patients either get whole breast radiation alone if they're in the breast conservation setting, or whole breast radiation and regional nodes. And they have to have the IMNs treated. Protons are not eligible. You're not allowed to treat with protons in this trial, which is interesting for left-sided cases. And then in the mastectomy setting, it's either no radiation at all versus comprehensive radiation. And so they're trying to accrue 2,100 patients for this. Right now, they're at 1,600. So they have been accruing. Now, I don't know what the Supremo results are going to do to their accrual numbers, because it's a big chunk of their population. But before the Supremo results, I would have offered this trial to this patient. So it's interesting. A couple other things I wanted to touch on from a radiation perspective is how we treat. And the way that we treat, the number of treatments has changed dramatically over the past few years. This trial, which is a Chinese trial, and there's some other ones too, was a hypofractionated versus conventional. So it's basically 16 treatments versus around 28, 25 to 28. And this was a randomized phase 3 trial that randomized these patients to either fractionation scheme, and they basically found there was no difference in local regional recurrence or overall survival. There was a little better cosmesis in the hypofractionated arm, and this led to most people now treating the majority of patients with hypofractionation. With photons, this was a photon trial. And so they had 820 patients randomized, 50-50. And so, so these, one caveat is they didn't treat level 1 and 2, which was dissected axilla. Some trials don't include dissected axilla in the radiation fields, which also is TAILOR-RT does not. It depends on the type of surgery, actually. And they didn't include IMNs. And so, again, they were considered non-inferior. There were certain patients that were not included in this. No one with more than 10 lymph nodes positive was included, so I do not hypofractionate people with 10 or more lymph nodes. T4 disease is not appropriate for hypofractionation. They were not included. But this, again, is a de-escalation trial because it's less treatment, and honestly, the cosmesis is better. So that's one other trial. And then this is another ongoing trial that they didn't look at reconstruction on that last trial. And so this is a reconstruction trial that specifically is going to look at hypofractionation versus standard fractionation for reconstructed patients, which is a very big question, especially in this community where we have a lot of reconstruction. And one of the main risks of radiation is capsular contracture, which it's pretty high depending on surgery type. And so it's the hypofractionation question, whether it leads to more or less of that will be very important to determine. One other trial which we have open at our institution and is a multi-center trial is called COMPRO or BR009. This is a specifically proton trial that is looking at 2 different fractionation schemes. So if this patient, if we decided to treat this patient, if she wasn't a Supremo patient and we were going to treat her, she had something a little different clinically, then I would choose to treat her with protons because this is left-sided. And the fractionation scheme is important. And so we don't hypofractionate with protons. And that's because with reconstruction right now, because there's no data to support that, and we don't know if there's more toxicity. So this trial will be very important. It's a 1-to-1 randomization it's a very pragmatic trial, stage 1 to 3 patients, so they can have N1 disease, N2 disease, who require post-mastectomy radiation with proton therapy, and they either get randomized to 15 fractions or standard fractionation, which is either 25 or 28 fractions. And it's going to be very important to see that. And so why do we use protons in left-sided cases? Well, the reason is because protons have a distinct physical property called the Bragg peak compared to photons. And because of that Bragg peak, the dose, if you look at the right side, those are two craniospinal treatments. The top one is a photon-based treatment, and the bottom one is a proton-based treatment. And what you're seeing on the bottom one is the Bragg peak effect, is that the low dose area, which is really the dose that is anterior to the vertebral bodies, and you can see that on the top one, there's that a low dose bath. But in the bottom one, there's no low dose bath. The dose stops. And so you're able to spare all those thoracic and abdominal normal organs, or organs at risk, we like to call them. And in the bottom left, you have a brain patient, where on the left, again, is protons, and again, there's no low dose bath to the normal brain. And this is very important in children. This is very important in brain tumors where we have a lot of critical structures, but it's also important in left-sided breast cancer, where the IMN nodes are basically laying on the heart. And so we can get much better dose distributions with that. And this was just an example of that. If you look, these are three different plans. One, the left is 3D conformal, which is probably the least conformal technique. IMRT, which is a sophisticated photon technique, and then IMPT, which is intensity modulated proton therapy. And if you look at the bottom, you can see that the right side, the proton one, has the best dose distribution with the least lung dose and least heart dose. And you can see it avoids the low dose bath. The middle one has a low dose bath to the heart and lungs. And then the one on the 3D has, it's difficult, might be difficult to see this, but it has high doses. The red indicates high doses involving the flank and even in the breast that we're treating. So you don't have as much control over your dose. And this is another example of just crafting a plan with protons treating the bilateral chest walls where you completely avoid the heart. And you can see that the chest walls, the targets, the right side you're treating the IMNs, they just lay right on the heart. And you're able to completely avoid it. You can only achieve this with proton therapy.
Okay, thank you for that excellent discussion regarding the radiation aspects to this case. We do have a little under 10 minutes if anyone has a question. Also questions coming through on the virtual audience. Please feel free to raise your hand. Reina will.
On this, can you hear me? On the slide with the PARP inhibitor, the slide mentioned BRCA2 patients, but are the results applicable to BRCA1 patients as well? Because the slide just said BRCA2.
Yes,
Okay,
it's
thank you.
germline, BRCA 1 and 2.
I think we have a question back here.
Since there is no radiologist there, I want to make a comment. Because when you send a patient that is BRCA 1 or 2 for yearly mammogram and MRI, I think we should do mammogram, and if the breast is dense, ultrasound, and then 6 months later, MRI, because no way that a cancer would grow 1.9 centimeters in 6 months, you know. Therefore, this is not done, and that the higher things say, oh no, if you do MRI, you don't need ultrasound. I said, you do MRI 6 months later. And that I think what should be done is not done.
Dr. Lesnikowski.
Hi. In this case, the axillary dissection took out 9 lymph nodes. Would your approach have been different if the axillary sampling be 5, 6 nodes, for example?
Sentinel, let's say. I was hoping you wouldn't ask that.
Yeah, I mean, 9 nodes in a sentinel.
Yeah.
I'm a breast surgeon. I don't think I've ever done a sentinel node and take out 9 nodes.
Right. Yeah, it's very controversial, and we don't really know what to do. So I would have a discussion with the patient. I would talk to them about Taylor RT because they would be eligible for that trial. I'd probably review it with my group and maybe even take it to tumor board. But right, there's no data that supports not treating in that particular case. And I think that you have to weigh the clinical risk factors too. So for instance, if she had extensive lymphovascular invasion on the node, okay, or extranodal extension, it would push me to lean towards treatment of that. If she, and the patient's age too is important. So all these things, she's high grade, if with one lymph node, sentinel lymph node biopsy, high grade tumor, extensive LVSI, extranodal extension, I'd probably treat that. But it depends. Anyone would do it case by case at that point.
So Dr. Panoff, a question that's come through from the virtual audience, is proton therapy in use or still being studied? Which centers are using this in real time?
Yeah, it's a great question. So it's definitely not experimental and in use. I would say that when I finished my residency, there were 5 proton centers, and I think now there's 35. And multiple under construction. There's a heavy ion facility. I think that's Stanford is building, or it could be also one in Jacksonville, I think, which is going to have carbon ions. But it's widely used, and we have a cooperative group. There's a trial which I did not show, but called RADComp, which recently closed to accrual and enrolled 1,200 patients, and they were randomized to photons versus protons. So again, a pragmatic trial. T1 through T3, N1, N2 disease, and just 50-50 randomization. When we have that data, it's a 10-year outcome, looking at cardiac morbidity, that's the primary outcome. So it's not overall survival or local control, because we don't expect that to be different. That will be game-changing, based on what that shows. But it is not, we don't consider it experimental. I treat most of my left-sided patients who have regional nodes. Now, the insurance companies make it challenging to get approval for many patients. And so and there will some that will deny it based on that. But there's lots of data to support proton use in 2025.
Dr. Lesnikowski.
This was just a comment on the screening. My understanding of adding ultrasound concurrent to mammogram to a woman who's undergoing MRI screening 6 months later is that you don't increase the cancer detection yield, but you increase the benign biopsy rate, decrease the quality of life, and increase the anxiety for the patient. So it hasn't been my habit, based on that data, because that's data from studies, to do a 3-pronged approach. That's just been my approach.
Yeah, I think if it's a very dense breast and you're doing a mammogram, you know that the mammogram, unless you do a contrast enhanced mammogram, a CEM, that we are going to miss about 60% of cancer or 55% of cancer. And the ultrasound may be helpful. Diagnosis a small cancer that 6 months later, you do an MRI. Yes, if the MRI is done at the same time, there is no reason to do ultrasound. But if the MRI is due 6 months later, especially in a premenopausal woman with high estrogen levels, if she's BRCA2, that usually is estrogen receptor positive, it may make a difference. We don't have a study to show this.
Thank you for your comment. I think there's a question here.
There's one there too.
Thank you. I just wanted to clarify, in this patient, would she get adjuvant chemotherapy or hormonal suppression? There was a lot of good data presented, but in the real world, if patient was in the office right now, I'm not clear what we would do. I think either one would be fine, it looks like, from the data presented, but I just wanted to some clarification. Thank you.
So this would be a patient that would be a candidate for the offset trial, and so I would really encourage clinical trial participation. We have that trial open at Miami Cancer Institute, but it does require that the patient would be okay with the idea of being randomized to chemo versus no chemo. The standard of care currently outside of clinical trial would be for adjuvant chemotherapy, given the benefit, which again, we're not sure if it's ovarian function suppression benefit versus cytotoxic benefit, but there is a benefit there. So standard of care would be for adjuvant chemotherapy. Given one positive lymph node, I don't know that I'd feel strongly about anthracycline. I would probably be offering her TC, maybe with consideration of 6 cycles as opposed to 4, given that positive lymph node. And then in the adjuvant setting, beyond chemotherapy would be ovarian function suppression, AI, abemaciclib, and would also be considering bone agent.
But if she had a lower oncotype, you wouldn't give chemo, right?
If she had an oncotype that was 15, well, for node positive, in our exponder, it was our recurrence score 0 to 25, and it showed a benefit. So for premenopausal. So if she had been node negative with a lower oncotype, then no benefit. Okay. But for the node because positive, premenopausal node positive, any recurrence score, they benefited from the chemotherapy.
There was no differentiation. Remember, we showed you the 0 to 13 and then to up to 25, and there was no differential benefit of chemotherapy based on that oncotype score.
They all benefited.
We are at time, but I do think there was someone here on this side who had a question, if it's quick. Okay. Dr. Tay.
Clarifying that for the offset trial, it is okay to use the CDK4/6 inhibitor afterwards?
Yes, and we just have to specify at enrollment whether or not the plan is to use CDK4/6 inhibitor, but yes, it's allowed.
Okay, and I'm just making a final check to make sure we don't have any questions.
One more.
We have one more, okay. I think you addressed it. If you gave chemotherapy to this patient, what regimen? So you mentioned you would consider TC.
I have a quick yes/no question. Would you, in your practice, are you ordering oncotype on premenopausal node-positive women?
Yes, I am.
In the current moment, I am, because I'm also looking for for patients that would qualify for the offset trial. According to NCCN guidelines, they say a genomic assay could be ordered for prognostic information, but not necessarily predictive in that patient population. So I think it gives us interesting information, but in the current moment, standard of care would still be for adjuvant chemotherapy outside of clinical trial in this setting.
Okay, thank you to the panelists for your excellent presentations and discussions of this complex case. It's now my pleasure to introduce my partner in crime, Dr. Neil Iyengar from the Memorial Sloan Kettering Cancer Center, and he will be taking us through the early stage triple-negative breast cancer case.
Perfect. Hi, good morning, everyone. Well, it's a pleasure to be here. Thank you, Dr. Mahtani and Total Health for the invitation. I am very pleased to welcome this next panel to the stage. We will keep Dr. Adesoye up here as our surgical perspective, and I'd also like to invite Dr. Badve, our pathologist, Dr. Nanda, medical oncologist, and Dr. Gallagher, endocrinologist. So with that, we'll go ahead and get started here. So this panel will be focusing on early stage triple-negative breast cancer, and just like Dr. Mahtani, we'll start with a patient case to sort of guide our discussion here. I'm going to take you through the full course of this patient's history, and then we'll start to dissect it. So this is a 46-year-old woman with no past medical history, otherwise healthy, getting her yearly screening, and comes in with a new palpable breast mass. Her imaging at that point identifies a 2.5 centimeter highly suspicious mass in her right breast, as well as 2 abnormally enlarged lymph nodes in the axilla, and she's presenting with clinical N1 disease. She undergoes biopsy, which confirms a grade 3 invasive ductal carcinoma, triple negative with a HER2 IHC of 0. And there is a comment, and we'll touch on this shortly, with regard to the TIL infiltration at about 50%. She undergoes germline genetic testing, which identifies a pathogenic mutation in BRCA1. And there you can see her family history is also indicative of a genetic syndrome. So she undergoes complete staging here and no evidence of distant disease, fortunately. She then initiates neoadjuvant therapy per Keynote 522 with chemoimmunotherapy, and we'll go through that as well. She has a clinical response with reduction in the mass as well as the axilla, and this is followed by a right mastectomy and sentinel lymph node biopsy, contralateral risk-reducing mastectomy as well. And pathology review at that point shows treatment response with scant residual invasive carcinoma cells characterized as a residual cancer burden of 1 and a complete response in the axilla. During her adjuvant therapy with pembrolizumab, her course is complicated by 2 hospitalizations for severe diarrhea and colitis. She also develops severe fatigue, which limits her ability to return to work, and she's noted to have low AM cortisol levels, which prompted a referral to endocrinology. Her pembrolizumab was ultimately discontinued because of the severity of the colitis and diarrhea and also the fatigue. She was treated with corticosteroid, and we'll go through that management as well. She has symptomatic improvement and then ultimately initiated adjuvant olaparib, and she remains on the adjuvant olaparib at this time. So here are the management questions that we'll go through. We'll start by discussing the optimal surgical approach here, as well as the approach to axillary sampling or surgery, the value of residual cancer burden, and whether or not that influences our adjuvant therapy decisions, as well as the role of TILs in triple-negative breast cancer. We'll discuss her neoadjuvant therapy approach, as well as the management of immune-related adverse events, and finally, the use of all of the potential adjuvant therapies we have available to us, including continuation of pembrolizumab, the role of capecitabine per the CREATE-X trial, and PARP inhibition. We'll be a bit brief on the PARP inhibition since that was covered so well in the prior panel. So let's start with the surgical approach, and I'll turn it to Dr. Adesoye to take us through that as well, particularly for this patient with triple-negative breast cancer undergoing neoadjuvant therapy.
Thank you. So like I discussed earlier, patients who are undergoing breast surgery have the option of breast-conserving surgery or mastectomy. And the way we think about which patients would be right for either, we consider oncologic factors. How big is this tumor? Can I get clear margins? We consider cosmetic factors. How big is the tumor size relative to the breast size? And of course, the patient preference. What does the patient prefer? Do they prefer breast conservation that is accompanied with radiation therapy, or would they prefer mastectomy? But in the neoadjuvant systemic therapy setting, one of the things to really consider is that breast conserving therapy is an option for many patients after treatment, as they will respond, and you can see significant downstaging, especially with triple-negative breast cancer. And so I anticipate this response, and I plan accordingly. I will get an ultrasound midway through treatment, and then ultrasound with mammogram plus or minus MRI at the end of treatment, and again revisit this discussion with the patient. And it's important to biopsy any area prior to systemic therapies in case the patient does become a candidate for breast-conserving therapy. I've certainly seen situations where the patient didn't get some areas biopsied. They thought they were just going to do a mastectomy, and then at the end they're like, well, can I do a breast-conserving therapy now that I've responded so well? And then it puts you in a pickle. Of course, you want to discuss reconstruction. If the patient responds really well, then you can just do local tissue rearrangement. Sometimes you may need levels 1 to 2 oncoplastic reconstruction, and you want to engage a plastic surgeon early in case the patient needs implant-based reconstruction or autologous reconstruction. And so in terms of patients who are clinically node negative or clinically node positive but CN1, and they have clinical response during treatment, sentinel lymph node biopsy or targeted axillary dissection really are the approaches for nodal staging in this patient population. For sentinel lymph node biopsy, we recommend dual tracer with either isotope or blue dye. And targeted axillary dissection that I was describing earlier really is the sentinel lymph node biopsy with dual tracer, and you're combining that with localization and selective excision of the clipped node that is biopsy proven. And we know based on studies that we can lower a false negative rate for sentinel lymph node biopsy in the neoadjuvant systemic therapy setting by excising 3 or more lymph nodes using the dual tracer mapping technique and excision of that clipped biopsy-proven node. Now, there's a multi-center retrospective study that did compare sentinel lymph node biopsy with targeted axillary dissection, and then they showed no difference in clinical outcomes between both techniques. So depending on which institution you're in, some institutions will do the targeted axillary dissection approach, and some institutions will do the sentinel lymph node biopsy approach.
This patient had a sentinel lymph node biopsy. Do you agree with that approach for this patient?
So she had clinical N1. She responded during treatment. I think that's perfectly reasonable.
Very good.
And so for patients who are clinical N1 who respond excellently well like she did, they have a pathologic complete response in the axilla, and this can happen anywhere from 21% to 65% of patients. It varies by subtype. For hormone receptor positive, it's much lower. Like I mentioned earlier, it's under 10%. Omission of axillary lymph node dissection is standard of care in this patient population. If on sentinel lymph node biopsy or TAD, they do not have residual nodal disease, you can forego the axillary lymph node dissection. And, like I said earlier, the sentinel lymph node biopsy, the false negative rate has been shown to be reasonable in this setting. And what we've seen is that these patients have low rate of axillary recurrence, and we have 5-year data to show this as well. Now, as was mentioned earlier, regional nodal irradiation can now be omitted in this patient population, even though they've not published the manuscript. But at our center, they're certainly considering this for patients on a case-by-case basis. So what about, CN1 patients who continue to have residual disease in their lymph nodes? And based on ECOSOG C1071, this can be 58.9 to 60% of patients. For these patients, axillary lymph node dissection is the standard of care at this time. We do have the Alliance trial, A011202, that is really asking the question, is regional nodal irradiation non-inferior to axillary lymph node dissection? And so they randomized patients with CT1 through 3, CN1 disease, either micrometastatic or macrometastatic nodal residual disease on sentinel lymph node biopsy or TAD. And they put these patients to receive axillary lymph node dissection with regional nodal irradiation to the undissected axilla versus regional nodal irradiation alone. Now, they presented the results of nodal burden at San Antonio just this December, and they showed that a little over half of these patients have only one positive node, and about 20% have 3 or more positive nodes. In the axillary lymph node dissection arm, they did see that 46.4% of patients had additional positive nodes with the axillary lymph node dissection. And this correlated with patients who had residual breast disease, patients who had clinical T3 disease, patients who underwent mastectomy, and patients who had a high number of positive sentinel lymph nodes. The oncologic outcomes are pending. We'll find out if you can radiate these patients like we do in the upfront setting, or do they need an axillary lymph node dissection, which is currently the standard of care. And so for patients that are clinical N2 or N3, axillary lymph node dissection is the standard of care. These patients should not be getting sentinel lymph node biopsy or targeted axillary dissection. And just to refresh our memory in terms of what clinical node N2 disease means, is fixed or matted level 1 to 2 axillary lymph nodes, or patients with isolated internal mammary lymph nodes. And CN3 disease, which are patients with infraclavicular or supraclavicular nodes, or patients with internal mammary nodes, as well as axillary nodes.
Great, thank you for taking us through that. So let's switch to the pathology here. And this particular patient, as you saw, had a very good response, but some scant residual invasive cells at the time of surgery. So let's talk a little bit about residual cancer burden and whether there are other useful prognostic or predictive features here. And for that, I'll turn to Dr. Bodve to take us through residual cancer burden.
Sure, thanks. So whenever you treat a patient, there are possibly 4 outcomes. A, the tumor does not dissolve at all. It's as though nothing happened. B, the tumor could kind of partially resolve. C, there's nothing kind of left on gross examination, but on microscopy we find a few cells. And then D, we have no tumor either on microscopy or on gross exam. So nothing whatsoever, clean slate. And that's basically those 4 categories have been more scientifically defined using what is known as the residual cancer burden. So what you do in this particular calculator, it's an online calculator. You just plug in some of the values that you have in terms of what was the tumor bed to begin with, what was the degree of cellularity, what is the percentage of in situ tumor, and what is the nodal status. And based on that, you identify these 4 categories. So RCB 0 means there's no residual tumor at all. RCB 1 is microscopic disease, as we had in this patient. RCB 2 is disease that is grossly measurable, and RCB 3 is gross disease. Did the patient ever get therapy? So those are the 4 categories that we define. And of course, those are prognostically important. And as you can kind of see in this particular plot, the plot A is the same as you saw in the previous slide, which is what you expect in your classic triple negative patients. However, it changes. Before I go into that, if you can see the blue and the yellow line, which is RCB 0 and RCB 1, more or less overlap over each other, and they are associated with very good outcomes, while RCB 2 and 3 are associated with poor outcomes. In plot B of this figure, what you can see is an ER-positive disease. And for some unknown reason, the yellow line, which represents RCB1, that is microscopic disease, seems to have a better outcomes that is statistically significant over RCB0. And of course, as expected, RCB2 and 3 have worse outcomes. In the bottom, you see in plot C is HER2-positive disease, and as again expected, you see a nice play of the RCB 0, 1, 2, 3 based on chemotherapy regimens. But in plot D, once you start treating with Herceptin or targeted therapy, you can see that the plot changes quite significantly in outcome. So the point I'm trying to make is the prognostic impact of various RCB classes depends on the treatments, depends upon the subtypes of tumor, and you need to be a little more careful and just saying RCB 0, phenomenal outcome or not. So we need to be careful based on the type of tumor and the treatment that the patient received. So this is more about residual cancer burden. The other prognostic factor that comes in is tumor infiltrating lymphocytes. So traditionally, we have always looked at the tumor itself and talked about the grade of the tumor, how ugly the tumor cells are, et cetera, et cetera. In the late 1900s and early 2000s, we were looking at angiogenesis, and there were all of this Avastin-based therapies, which unfortunately did not work well for breast cancer. But in addition, in the stroma, we have blood vessels, of course, we have fibroblasts, but we also have immune cells that react to the tumor. So the amount of immune cells that are in close proximity with the tumor do make a significant difference in terms of outcomes. And it was first shown in Big 298. We showed it in 1199, 2197. And based on that and a number of other trials that were done around the same time, this paper was published, which was a meta-analysis of almost 3,000 patients that had received chemotherapy of one flavor or the other. And what we basically found was if we divide into two subgroups the amount of tumor-infiltrating lymphocytes using a 30% cutoff, we could very nicely define a good prognostic category and a bad prognostic category. So far so good, patients treated with chemotherapy. Next slide. So when you have patients who have prior chemotherapy, and then we are looking at residual cancer burden, or looking at residual disease, we need to modify the criteria a little bit when you are evaluating the tumor. In primary tumors that are untreated, it's easy because that you have the tumor, there is no limited necrosis, limited fibrosis. But as we get into the residual tumor post-chemotherapy, we need to be slightly better in defining what is tumor, what is not tumor, which areas to look at. Of course, you want to look at the entire tumor region, but still you need to avoid areas of necrosis, fibrosis, macrophage reaction. So all of those things are what are listed on this particular slide. But by and large, the moral remains the same, that you want to look at viable areas of tumor and score it across the entire section rather than hotspots within the tumor. Though the question then comes up is, okay, TILs are prognostic. Can we use this information for patients who may want to not get chemotherapy at all? So this was a study that was more recently presented or published in JAMA Oncology, JAMA 2024, data from 13 different groups all across the world, from Canada right down to Japan, and they collated cases that were not treated for chemotherapy, so early stage triple-negative patients who did not get any chemotherapy whatsoever. And what you can see in this slide, that the TILs are prognostic no matter whether the patients received chemotherapy or not. Now, what's the importance of this? So, as you can see, if the patients have really high levels of TILs, 50 to 100%, their recurrence risk is quite low. So can we think of optimizing therapy for this patient population? And there's a lot of discussion going on for this particular patient population as to, are there trials that we can design to optimize chemotherapy or treat them only with ICIs or those kind of therapies. So again, watch this space because a lot of new information and a lot of energies are focused in that particular area. So I'll stop here and hand it back.
Great, thank you for taking us through that. And I think this is particularly exciting with regard to the potential for further personalization and maybe even de-escalation. So let's take a dive now into systemic therapy and the neoadjuvant approach to this patient. And I'll turn it to Dr. Nanda to walk us through neoadjuvant systemic therapy.
All right. Thank you, Dr. Iyengar. So I wanted to start just by, reminding everyone, what are our indications for giving neoadjuvant therapy? Because it's really evolved over the years. It used to be historically that we would give neoadjuvant therapy to patients who, our surgeons wanted to try to breast conserve because the patient wanted that, but their tumors maybe were too big and their breasts were too small to allow for that. And so that, that is certainly still an option for neoadjuvant therapy. I think that most recently, particularly for HER2-positive and triple-negative breast cancer, though, what we do after neoadjuvant therapy really depends on the response that patients have. And we know that adjuvant therapies can improve outcomes for patients who do not have a pathological complete response. So I think more and more now, at least for our stage 2 and 3 HER2-positive triple-negative breast cancers, neoadjuvant therapy should absolutely be the standard of care. And it still doesn't happen a lot. You know, I got an email on my way here from a local medical oncologist who said, you know, she had a T2 N0 triple negative breast cancer who went to surgery first, and now she's like, what do I do? Do I give her immunotherapy? So I think it's just really important to recognize that for our node positive, HER2 positive, triple negative patients, absolutely there's a role for neoadjuvant therapy, tumors that are 2 centimeters or larger, again, because what we're going to do after will depend on the response that patients have to our neoadjuvant regimens. Obviously, diseases like inflammatory breast cancer, there is an indication for neoadjuvant therapy. And then I know that you've already heard about hormone receptor positive breast cancer, where we kind of fumble around and we're like, you know, do we give neoadjuvant? Do we just take them to surgery? And so there are other factors, and sometimes our genomic assays can help us, you know, determine if somebody's going to benefit from chemotherapy and if we might want to consider giving chemotherapy in that neoadjuvant setting. I have to say my surgeons now are getting to the point where, you know, they want me to give neoadjuvant therapy to smaller and smaller tumors in the case that there's some micrometastatic disease in the axilla. They just don't want to know about it. We don't want to know about it. And can we, you know, potentially de-escalate therapy? And so we also need to be very cognizant that if it's really unclear how much invasive disease a patient has, that we do want to consider, you know, if there's like a ton of non-mass enhancement and we think most of it's DCIS and probably very little invasion, then that may not be the person that we want to give neoadjuvant therapy to. So I just wanted to kind of address that up front before we dive into the data.
Yeah, I think that's really helpful, especially with some of the discordant results with regard to when you start immunotherapy in the neoadjuvant or adjuvant setting. So thanks for walking us through that.
Yeah. So the current standard of care for stage 2 and 3 triple negative breast cancer is the Keynote 522 regimen, which I like to call everything but the kitchen sink. And so I'm hopeful that in coming years we'll be able to optimize therapy to other chemotherapy backbones, or, you know, based on the very nice talk that Dr. Badve gave, you know, for those patients who have robust immune infiltrates, you know, are there opportunities to optimize therapy? And there are many trials ongoing that are looking at questions like that. But the Keynote 522 trial looked at adding a year of pembrolizumab starting in the neoadjuvant and continuing on in the adjuvant phase for patients with stage 2-3 triple negative breast cancer, layered onto a chemotherapy backbone of platinum, taxane, followed by anthracycline-based therapy. So you can see here the mature data from the Keynote 522 trial. We saw that those patients who were randomized to pembrolizumab had a significant improvement in event-free survival. A delta of 9%, you know, almost 10% there is really impressive when we think about just what chemotherapy alone does for these patients, where we see, you know, 3% benefit. So impressive. And then what we saw at ESMO this year is that there's also a survival advantage associated with giving pembrolizumab to these patients. So this has really solidified the role of pembrolizumab plus chemotherapy in the neoadjuvant space for patients with triple negative breast cancer. When we look at some of the subgroups here, really all of the subgroups benefited from the addition of pembrolizumab to chemotherapy, regardless of PD-L1 status. So whether patients had some degree of PD-L1 expression or were PD-L1 positive, at least extrapolating from the metastatic setting, a combined positive score of at least 10, patients benefited equally, whether they were PD-L1 positive, PD-L1 negative, node positive, and we'll look at some of that data. So here, looking at outcomes, you know, these are all pre-planned subgroup analyses, but looking at benefits by stage. So you can see here for stage 2 and stage 3 disease, there was still an advantage to adding pembrolizumab. So, you know, if you're tempted, like, oh, this is just a stage 2, maybe we don't need to add pembrolizumab. Well, they also benefited from the addition. So clinical features like that, node positivity, node negativity, really don't tell us who are the patients who are going to benefit. Node negative patients benefited. So again, you know, that email that I got for this T2N0 triple negative patient who's had surgery, well, she's missed her opportunity potentially to benefit from the addition of pembrolizumab. Moving on to think a bit about the adverse events. For the most part, you know, treatment-related adverse events are not different between the two arms, whether patients got pembrolizumab or chemotherapy. But what we did see was obviously a significant improvement in immune-related adverse events. That's the next slide. And so here, you can see that for those patients who received pembrolizumab, this is our concern. And I think for all of you who've used this in your patients, and this case that we're going to be discussing here, obviously patients who receive pembrolizumab are at high risk for immune-related adverse events. You can see here the most common, are infusion reactions, rash, things like that. But the endocrinopathies, and we've got our wonderful endocrinologist here who's going to, dive into some of this more in detail, are real concerns. These are irreversible for patients. Thyroid disease, maybe not such a big deal. It's so prevalent. You take a replacement therapy in the morning, it's not a big deal. But when you think about things like adrenal insufficiency or hypophysitis, diabetes, those are very impactful on patients and their quality of life. So I'd like to point out that, they split out adrenal insufficiency into primary and hypophysitis here, but when you add those two together, it's 4.5%. 0.5% of patients who participated in this trial ended up with type 1 diabetes. So 5% of patients, so 1 out of 20, is going to end up with an irreversible endocrinopathy that's largely going to impact their life. I left out the thyroid abnormalities there, which are 15 to 20%, which I think are, pretty prevalent in the general population too, so not as impactful. But that is just really something that you want to think about and talk to your patients about. And I'm not even talking about the hepatitis, colitis, pneumonitis stuff that we deal with, and it makes it very challenging for our surgeons because we pass them off with all these steroids that they've got on board, and, it can lead to delays and things like that. Next. This is real-world Keynote 522 toxicity data. This was a large, almost 600-patient look at patients who received this regimen out in the real world. And we've seen this in the I-SPY2 clinical trial, and we've definitely seen it in real world. We're seeing much higher rates of these immune-related toxicities in real-world practice than they saw in Keynote 522. I cannot explain it. I don't understand it. But again, I think there's more and more data here looking at primary adrenal insufficiency, hypophysitis, and diabetes in this real-world data set. These numbers are much higher. We're looking at 10% of patients experiencing some of those toxicities. Next. And hospitalization rates in this real-world data set, 40% of patients ending up, 30 to 40%, it varied a little bit by race, but, a large proportion of patients ending up hospitalized with some toxicities from this regimen, be it neutropenia or some of these immune-related toxicities.
All right, very striking. So thanks for highlighting that. I think that the point about the real-world data versus what was observed in the clinical trial is really important. And so with regard to these immune-related adverse events, let's turn to Dr. Gallagher, our endocrinologist on the panel, to walk us through some of these adverse events, even in greater depth, and how we might manage them.
So thank you. Just to kind of address two things that are not in these slides, but part of the reason the real-world data doesn't match with the clinical trials data is actually because in real-world data, we had no way to code for immune-related adverse events until literally January 2025. So there's now an ICD code that actually is for immune checkpoint inhibitor specific side effects. And so previous to this, it was really how the person who saw the patient coded the adverse event. And then the second thing was in the earlier clinical trials, they actually excluded people with pre-existing autoimmune disease. That doesn't happen in real-world data, in the real world either. People who have pre-existing thyroiditis or something are included in treatment. And so these are two partly of the reasons that we think we're seeing different numbers. I'm an endocrinologist, so I'm obviously going to focus on the endocrine side effects. The other thing is if you look at that clinical trial data and then the Keynote 522, they've separated out thyroiditis, hypothyroidism, hyperthyroidism. In reality, they're all the same thing. So there's just different phases that you develop of the same disease, which is essentially a thyroiditis that people get with the immune checkpoint inhibitors, and that's by far the most common of the endocrine adverse events. As you say, it's not long-term, it's not an issue because most people end up hypothyroid. The main issue is that these adverse events happen typically within the first 1 to 3 months, up to maybe 4 months. And the issue from our multidisciplinary side is that when we're sending our patients to surgery, to our surgical colleagues, we don't want to send somebody who's floridly hyperthyroid off to surgery or somebody who's potentially adrenally insufficient to surgery. And so that's kind of the biggest that window in the neoadjuvant setting is a little bit unique to breast cancer now, because that's literally when people are developing some of these side effects. So as you see here, essentially the side effects are, the most common ones you see are thyroid. Rash often coexists with the thyroid side effects, so we often see the two come in together. And then, as you said, the more serious ones can be pneumonitis and colitis. And from an endocrine perspective, it's important for us because people who get almost any other side effect go on high doses of steroids, and that can also impact our endocrine labs and make us unsure if somebody also has an underlying cortisol deficiency as well. So this is the time frame, yeah. So as you can see, essentially, a lot of these side effects occur in the first, usually it's the first 3 months, to be honest, if you're watching very carefully, but often they're picked up within the first 6 months. And again, in real world data, it depends on the institution and their algorithm. And like, so you probably are aware from the medical oncology side, a lot of the time there are these data set order sets that kind of go in with basically like check TSH every other treatment or every treatment, and not every, even within our oncology group, not every single oncology group does exactly the same thing. And so sometimes in real world, with the exact time point when these are picked up are not real, they're sort of just more when they're picked up in clinical practice. So as we mentioned, so pembrolizumab is an anti-PD-1 monoclonal antibody. We've been seeing it in other cancers for many years now, and so we're fairly familiar with it from the endocrine side. So primary thyroid dysfunction is the most common, and in real-world data from other cancers, it's been reported in up to 40% of people. So it can be quite high, actually, even higher than you saw in the breast cancer studies. Hypophysitis is typically associated with anti-CTLA-4 monoclonal antibodies that you're not using in breast cancer but are getting used in melanoma. And what we are seeing cases of hypophysitis, which is essentially adrenal insufficiency in people on pembrolizumab as well. Less common, but definitely well described. And then this autoimmune type 1 diabetes, to me, is almost the worst of the complications because it's irreversible. It basically wipes out people's beta cells, and they're then dependent on insulin for life. And it's really life-changing for people if they develop a type 1 diabetes. So this is just from some of the previous clinical trials, just looking at the rates across the anti-PD-1, anti-PD-L1 monoclonal antibodies. So for hypophysitis, as I said, the rates are fairly low, but it's generally happening within the first kind of 3 or 4 months, and that's pretty typical. Adrenal insufficiency, in my mind, it's very dependent on who's actually seeing these patients and how they're working them up. But it's really, the vast majority of these people with adrenal insufficiency are really hypophysitis cases. Primary adrenal insufficiency is actually much less common, but it just really can get misclassified because people just put adrenal insufficiency in the chart and don't distinguish between which one people have. So it's sort of, to me, most of it is actually hypophysitis. So the symptoms to look out for, unfortunately, in an oncology population can be vague, and this is why it's sometimes missed and why it's hard to diagnose. Fatigue is the most common one, and in younger people, I feel like they tend to, if it happens in that first 1 to 3 months, the symptoms tend to be more severe in that they'll say, like they're like a textbook, and they'll say, I literally can't get out of bed in the morning. And so there are some people who will have that, and they'll have the loss of appetite. The weight loss takes longer to happen. The other thing is if people are on blood pressure medications, they find that their blood pressure is dropping. If they're on diabetes medications, they stop taking their diabetes medications because their blood sugar goes low. So you can get the whole picture together, or you can just get somebody who has sort of this vague and less kind of specific fatigue. So you just have to be mindful of it. With hypophysitis specifically, you can also get headache and visual change. The headache usually comes if the pituitary enlarges significantly with the hypophysitis, which doesn't always happen, but can definitely sometimes happen. So if you get severe fatigue with headache and you visual changes, you definitely should think hypophysitis. And then the problem with testing the hormones is that they have a circadian rhythm, so you have to test morning cortisol if you have people coming in. This is why it's not really recommended to do just sort of screening of cortisols, because people can come in for their infusions at any time during the day. If you have a 4 p.m. cortisol that's like 3 or 4, it really is meaningless. And so although they'll generally do pre-treatment TSH levels, because that is helpful, pre-treatment cortisols on just random cortisol levels with people with no symptoms is typically not very helpful. The most common axis, unfortunately, that is affected by in hypophysitis is the cortisol and ACTH axis, and that's just unfortunate in many ways because it's the one that you need most, and so it's not ideal to have no cortisol, again, if you're going to go to surgery. And the one that's least affected, but is kind of an emerging topic, is the reproductive hormones, because They do tend to go down sometimes, but they tend to be, they can often recover. But there is this whole question mark in women now who are younger women who are getting neoadjuvant chemotherapy and immunotherapy, how it's going to affect fertility and estradiol levels long term, even after they stop the treatment. So this is just one picture. It's not from our group. It's just a published picture of hypophysitis. So I'm not sure how familiar anybody is at looking at pituitary glands, but in the one in the middle, so this is a midline cut. I thought I might have an arrow here. I don't know if you want to point to the pituitary, but essentially you can see, if you look at the left picture, you can see the top of the pituitary is usually a little bit concave. And then in the middle, the kind of white, gray-white thing in the middle, you can see it's sort of enlarged and it's more like a little kind of ball. And then when it resolves on the other end, the top becomes concave again. So this one is one that you can actually see something in oh, I can do it.
I might have to use that screen over there.
Sorry. All right, so for people not looking at pituitary, this is the pituitary in the middle, if you just don't look at them all the time. So essentially, so it does resolve, and you don't always have to do an MRI, because often, unless somebody has a headache or visual change, if they just have the symptoms of fatigue, often there's nothing on the MRI scan, or you've missed it because it just was very transient. So we don't recommend necessarily getting an MRI on everybody. So as I said, so ACTH and TSH are usually lost most frequently. The LH and FSH are the reproductive hormones, not always checked, and poorly understood essentially what the effects are going to be long term. People almost never check the growth hormone IGF axis. When I have checked it, it's usually normal, but it's not really critical, and you wouldn't replace this in somebody with cancer anyway, so it's usually not checked. And there are these rarer cases, but a couple of groups, including ours, have described this now, where there are these delayed hypophysitis cases in people specifically on pembrolizumab. So it seems to be delayed out to 18 months, and some people have even described it later than that. So if you have somebody who was ever treated and they're coming back with new symptoms of fatigue, it's just something to keep in the back of your mind, that it's not clear how common those cases are. And then, as I said, the MRI is not usually indicated. So the ongoing challenges are, as the symptoms might be specific, it is evolving. So this is the other difference kind of with general endocrine things, in that usually if you have somebody who comes in with possible adrenal insufficiency, you check their cortisol, you know, it's fine, you kind of say it's not adrenal insufficiency. The problem with this is that it evolves, so you can check it 1 week and it looks fine, and 2 weeks later they have no cortisol, because it's an inflammation that just evolves quickly over time. So if the symptoms are there, even if it's normal 1 week, you should just recheck again in about a week or two just to make sure it's still normal. There's no clinical anti-pituitary antibody, so there's nothing specific we can do except for the cortisol to check it. The ACTH has to be drawn on ice, so you need to make sure your lab is sent it off properly, or else you get a positive on that. And co-centropin stim tests are usually useless, so if you have somebody who you're referring these patients to and they're not very familiar with the actual immune checkpoint inhibitor hypophysitis, normally endocrinologists will want to do a co-centropin stimulation test. That is dependent on the adrenal glands responding to the co-centropin, and your adrenal glands don't atrophy for a number of days to weeks after you lose the ACTH, so you can actually get a normal co-centropin stim test in somebody with hypophysitis, so we do not recommend people doing that. So the treatment from our perspective is basically replacing the glucocorticoids. We don't recommend holding the immunotherapy because of endocrine side effects in almost all cases, unless somebody comes in with enlarged pituitary visual symptoms and a headache. In that situation, we would give high-dose steroids to calm down the inflammation in the enlarged pituitary gland, and would recommend just temporarily holding the pembrolizumab. But in somebody who has hypophysitis without central symptoms, we don't recommend stopping the oncology treatment. We will just treat through, and usually we'll just replace the glucocorticoids. The other thing is just, like, if in doubt, if you have somebody and they need to go for surgery and the cortisol sort of in the middle and we're not too sure, we would treat and say go for surgery. So we can always figure it out after the surgery, but the safest thing to do if you aren't sure is give hydrocortisone, send somebody to surgery. When they recover on the other end, send them to the endocrinologist, and we'll figure out if they need to stay on it or not. And then this one is sort of my favorite slide in many ways, because half the time I feel like I'm sort of like a detective and trying to figure out when it's not actually hypophysitis. And so again, it's important just because if it is hypophysitis, usually if they lose ACTH, it's permanent and they're going to be on hydrocortisone for life. There are many times it's not hypophysitis. So if somebody doesn't, if you just get a cortisol on somebody and it's really low, but they feel fine or they're not really complaining of very specific symptoms, it can be many, many other things. So one thing is that a lot of these people will get other steroids for something, like for either the rash, and I've had people using like cortisone cream 7 times a day for like weeks because of this rash that's not being treated properly, and that's suppressed their cortisol because they end up absorbing it. You can get, uncommon with breast cancer, but occasionally you can get a pituitary metastasis, and so if somebody again has the headache, that's another reason that we would scan their brain, is just to make sure that we're not missing a MET. Appetite, again, not so much with breast cancer, but Magestrol that people take sometimes for appetite stimulation can actually suppress the excess. And then there were 2 FDA releases at the end of 2023 of various teas that were actually like herbal teas that actually had dexamethasone hidden in them. And so I came across at least one patient who was sent to me for hypophysitis who was actually just drinking herbal tea. And then the other thing is just night shift workers. So I have, like, people can be generally well, as you are aware, when they're getting these treatments. And so I have people who work nights come in the morning for their labs and their treatment and go home to bed for the rest of the day. And those people have a reverse circadian rhythm. So they come in with low morning cortisols, but it's actually their bedtime. And so you just, I mean, if you don't necessarily have to figure this out, but when you send them to endocrine, they should be thinking of these other things as well. The thyroiditis, as I said, is actually more common. It's like, as you said, if it's hypothyroidism, it's easy to treat. I think the main things are they can get a florid hyperthyroid phase at the beginning, which can be quite dramatic. And again, just going into surgery, you don't want somebody with a heart rate of 120. So we do want to diagnose this, and usually people will have screening TSHs before each treatment, and you can usually see this evolve over time. So the thyroiditis symptoms typically are fairly, in younger people, they tend to be fairly dramatic. In older people, you can have what we call apathetic hypothyroidism, where they actually have bad numbers but actually don't feel that bad. So generally, the hyperthyroid phase is the tachycardia, the sweating, the heat intolerance. Diarrhea can be from hyperthyroidism, not necessarily from colitis from the immune checkpoint inhibitors. And then on the other side, if they develop the hypothyroid phase, they can go around and be fatigued and bradycardic, cold intolerance, weight gain. Usually with these drugs, the numbers on the labs go off before they develop all these symptoms, so generally these are slower. And then the difference, again, for if you have an endocrinologist who's you're referring these people to, and they're more familiar with general endocrine than the immune checkpoint inhibitors, they may tend to say, come back in 6 months and we'll recheck it again, because thyroiditis in general that we see is like Hashimoto's thyroiditis. If you have a slightly abnormal TSH, it's probably going to take a few years for you to develop severe hypothyroidism. This is just an example that we published again a few years ago now, just looking at these original cases, and the dramatic thing to us was just how quickly this evolves, and so this is why you don't want to leave them for 6 months to come back and check again. They should be checked after like another month or 2 at most, after you've developed an initial, after the TSH levels are initially a little bit low. So this dramatic uptick is the TSH levels, which goes from almost undetectable to like 60 or 70 within a couple of weeks of it becoming abnormal. This is just the same sort of thing. Essentially what you'll see initially is a hyperthyroid phase. The T4 will go up, the TSH will come down. The T4 usually starts to drop before the TSH rises, and that's usually a sign for us that they're developing hypothyroidism. And if the TSH goes above 10, you can be almost sure it's going to be permanent hypothyroidism. Just again, this is just a unique thing to the immune checkpoint inhibitors in that you can get a very confusing picture depending on when you actually check them. So I think if you just click, it might pull up little boxes.
There we go.
You can, yeah. Oh, so go back one. Okay, yeah. So here is just a kind of to show you again that the person who's seeing these people needs to kind of be aware of how this evolves. And so if you happen to get the bloods at that particular time point when the TSH is high and the T4 is low, you could confuse it with primary hyperthyroidism, and sometimes these people end up getting treated with methimazole, which is not what they should be getting, because it rapidly evolves, and if you get the second phase, you can get a low TSH and a low free T4. That can be confused with central hypothyroidism, and then if you get them at the last phase, it's very obvious that they have primary hypothyroidism. So it's just, again, this is just to highlight that this is different to general endocrine things and that it evolves so quickly, and you can make a mistake on the diagnosis if you don't kind of do a serial measurements. So this is super tiny, but so essentially this says to monitor closely, that it's the most common side effect, essentially usually within the first 3 months. Hypothyroidism occurs quickly. you generally do never treat these people with anti-thyroid medications. You treat the symptoms with like beta blockers just to treat the tachycardia if they have that, or the tremor, just to get them through the hyperthyroid phase. There are very, very rare cases of Graves' disease, but these should be referred to endocrinology. They can be quite severe, but there's literally, the vast majority of these people are thyroiditis. There's just rare cases of Graves, so if it's not resolving quickly, then somebody should see them for potential Graves' disease. And then the other thing is, again, confusing. A lot of times I'll get like slightly low TSHs referred to me. This can be because of high doses of steroids actually will cause the TSH to be a little bit low. Other medications, people can get like amiodarone, obviously, tyrosine kinase inhibitors, and different other cancer treatments can also cause hypothyroidism. And then if you're doing CTs with contrast, that can sometimes just cause a wobble in the TSH and make it look like there's something going on. So the type 1 diabetes, as I said, to me is probably the worst one. It's usually a sudden onset, usually severe hyperglycemia. Again, same window, the first 3 to 6 months. And again, it can be an issue just if people are going to go to surgery and they start developing the severe hyperglycemia. Obviously, we need to catch it sort of early. It's usually dramatic in that you'll have somebody who has a blood sugar of, kind of 100 or 200 in the labs. The next thing it goes up to 200. The next thing it's like 800 within a very short period of time, and they often present with diabetic ketoacidosis. We check the autoantibodies, and usually they're anti-GAD antibody positive, so it's autoimmune related as well, and usually their C-peptide is undetectable, so often it's like 0.00, which is even more dramatic than people with regular type 1 diabetes. And then the features of new onset type 1 with immune checkpoint inhibitors from memory.
Some formatting issues.
Are, as I said, so it typically presents in a dramatic way. They are insulin requiring, and they're going to be insulin requiring forever. As I said, mostly they're autoantibody positive. And the other thing is just that like a lot of these immune checkpoint inhibitor side effects don't occur in isolation, so you can get two together sometimes. Again, so you just have to be careful of the diagnosis. This is sort of emerging. So although on one end of this there are these autoimmune type 1 diabetes cases, on the other end there's this other severe cases of lipodystrophy that have been described, which are severe insulin resistance. At the moment they're just case reports, but there's an increasing number of case reports on this. You can also get pancreatitis, obviously, so we usually will rule out pancreatitis in anybody who comes in with new hyperglycemia. And then it does seem like there is sort of a spectrum here, that there are people in the middle who develop kind of either a slightly more subtle inflammation of the beta cells or something and recover. So I think over time, we're going to find that there's more of a spectrum here on what this diabetes looks like.
Great, that was very helpful. Thank you, Dr. Gallagher, for walking us through that. So we're going to wrap up this panel now with sort of a look ahead, as well as adjuvant therapy approaches. And we're kind of running a little low on time, so I'm going to ask Dr. Nanda to take us through quickly some of our adjuvant therapy options.
So I think about 65% of patients who have triple negative stage 2 and 3 disease are going to have a pathological complete response, but that leaves about a third of patients who don't. And what do we do for these patients? And so that's why it's so critical that we do neoadjuvant therapy, not only for the immunotherapy benefit, but also it helps us tailor what we're going to do after. There are many trials ongoing in this space, so I always encourage patients to participate in trials. But our standard prior to the routine use of neoadjuvant immunotherapy was the CREATE-X trial. And in this trial, patients who had both hormone receptor positive as well as residual triple negative breast cancer after neoadjuvant therapy were randomized to 6 to 8 cycles of capecitabine versus observation. And again, patients who participated in this trial had not had immunotherapy, but what we saw was an absolute 13% reduction in the risk of distant recurrence-free survival, as well as a survival advantage. So I think many of us, outside of a clinical trial, will add capecitabine to the adjuvant pembrolizumab based on the CREATE-X data. For patients who have a germline mutation in BRCA1 or 2, the Olympia trial, we just saw an update at San Antonio this year, really improves distant recurrence-free as well as overall survival in mutation carriers. So in this trial, I'll just focus on the triple negative subset. Patients who'd had neoadjuvant therapy and didn't have a pathological complete response were randomized to a year of adjuvant olaparib versus placebo, and there was a survival advantage to adding the olaparib in the adjuvant setting to these patients. Again, this trial was done prior to Keynote 522 becoming standard of care. None of these patients have received immunotherapy, but now, based on this, we'll add olaparib to mutation carriers who have not had a pathological complete response. Next. There are many trials ongoing, though, to optimize therapy in the adjuvant setting. Here's just two of them. Optimize PCR and Optimize RD are a pair of trials that are going on through the cooperative groups. For those patients who do have a pathological complete response, and that's about 65% of patients, do they really need that adjuvant pembrolizumab? There are immune-related toxicities that can happen in the adjuvant setting. We studied in the I-SPY2 clinical trial the timeline of adrenal insufficiency specifically. The majority of patients who develop adrenal insufficiency from, and I'm lumping together that and hypophysitis, develop it while they're on treatment, but 20% develop it after they've completed therapy. So that's, 1 in 5 patients. And so do we really need to continue the pembrolizumab that might increase the risk of immune-related toxicities? So for those patients who achieve a pathological complete response to the Keynote 522 regimen, they're randomized to continuing pembrolizumab versus observation. For those patients who don't, we know that they're at higher risk for recurrence. And here, this trial randomizes patients to the current standard of care, which is continuing pembrolizumab or pembrolizumab plus capecitabine to sacituzumab govitecan for 8 cycles plus pembrolizumab. And that trial is actively enrolling now, still a long way to go. Next. There are also other trials ongoing looking at different chemotherapy backbones. The Scarlet trial is a trial which is looking at carboplatin plus docetaxel for 6 cycles instead of the Keynote 522 regimen. This is a randomized phase 3 trial, currently actively enrolling, looking to see, do we need the anthracycline-based component of this therapy, or could we perhaps just do the carboplatin and docetaxel? And that's based on a randomized phase 2 trial that showed similar outcomes. And then I think that is it.
Yeah, wonderful. Okay, great. So much to come in terms of whether or not we can de-escalate and how we should be managing these patients in the adjuvant setting with regard to combinations. Okay, so we do have some time, about 5 minutes for questions, and I know we've gotten a couple online, but let me open it up here. We have a question in the front.
I just had a question about patients who have uninterrupted pembro treatment, say perhaps in the adjuvant setting, versus those who have neoadjuvant treatment, say breast or melanoma patients, with a break in the pembro around their surgery. If the clock starts again after that break for endocrine, for autoimmune side effects, or if it's still really just in that first phase of the pembro, they either get it or they don't, and you don't really particularly worry about it when they restart their pembro after surgery.
Yeah, I mean, we can both comment on that, but for me, it's generally kind of the clock starts at the first treatment, unless you're going to combine it with something else later on. That's the only difference with like melanoma, and that sometimes they go on combination therapy, and that definitely increases the risk further. So if it's only one drug, then I would say it starts at the first time you give it to them, and then if they stay on that same drug, then the risk kind of reduces over time.
I'm just going to comment briefly on that too. When we looked, and I've looked at this a lot in the I-SPY2, neoadjuvant trial, the highest risk for immune-related toxicities is during the concurrent chemo immunotherapy. The risk in the adjuvant phase is much lower. It's still there, but I would argue you've already exposed patients to something. It may just take a while for the immune-related toxicity to sort of manifest. But also, we don't really interrupt. So I'm not sure what you mean by interrupting pembro. Pembro has very long half-life, probably 4 to 6 weeks. And so it really sticks around. So we don't generally, interrupt. for surgery. Like maybe they'll have, like a couple weeks extra in there. But I always give it concurrently with radiation. That's safe to give. So we just keep going. So at least in the neoadjuvant triple negative space, there's not much of an interruption.
So a practical question that will test your memory, Dr. Gallagher. Do you happen to know off the top of your head the ICD-10 code for endocrine disorders related to immunotherapy? We can always get that information
Come back
later.
to that question in 1 second.
Perfect.
And I'll find it.
Let's go to Dr. Bodve. We have a question about infiltrating lymphocytes, and also for Dr. Nanda. How is this important, or can this be important for predicting pathologic complete response? And is this something that should be routinely included? I know some centers do in the pathology report.
Yes, I mean, it's always good to provide as much information as one can. The problem often is logistics. Many groups, including ours, we tend to diagnose the breast cancer and send the report out, and then the biomarker reports are issued at addendums. So we don't know what is triple negative when we are signing out a breast cancer report. Because the biomarkers and followed by FISH, it just takes a week or two for that to happen. So giving that would be for every patient, and that's certainly possible. Certainly we know that the higher amount of TILs would be associated with the higher incidence of PCR. There's never a one-to-one correlation. It's a statistical association. But if you look at patients who did not get a PCR, the vast majority of them tend to have a low amount of tumor-infiltrating lymphocytes. So there is a good association, but it's not perfect. Does it help to have that information? Certainly. We try to put it as much as possible. But again, there is no uniformity. The CAP does not require it. So many people are a bit hesitant to include it in their reports.
Yeah, I mean, I think as the clinician who looks at the pathology report, I love it when my, pathologists say, oh, there's, a bunch of TIL here, like there's a lot of inflammatory cells, because I always feel good when I see that, because I think, oh, this patient's going to do well. But like Dr. Bodve was saying, practically, patient has a pathological complete response or they don't. And whether they had TIL or not is not going to impact how I manage those patients in the adjuvant setting. So I think, though, thinking about how we can maybe de-escalate moving forward, it's going to be a huge lift, because this isn't something that all the pathologists do. Dr. Bodve is an expert in TIL assessment and quantification because he's been involved in these working groups, but the vast majority of pathologists don't know how to really quantify this. So I think that there would have to be a real reason to do it, and right now I don't think that it's there.
That makes sense, actionable, yeah. And sticking with the issue of residual disease, we have a question from Dr. Rastogi with regard to patients who have a response but have residual disease. She's giving an example of YPT1A. Would you use capecitabine in that setting?
Yeah, so I always have a discussion with patients, because you saw Dr. Bodve show us residual cancer burden outcomes, and the RCB zeros and the RCB ones pretty much do about the same. And so it's a conversation that I have with patients. I had a patient with 0.2 millimeters of residual disease. We had that conversation. We decided together that she's just going to continue pembrolizumab in the adjuvant setting and not do capecitabine. So, I think it's a real discussion. Obviously the sort of Acento 5 optimized RD trial that I just showed you allows any amount of residual disease. But do I really want to give someone who's got 0.2 millimeters of residual invasive cancer in the breast and the axilla is clean and nothing anywhere else, 8 cycles of SASE with pembro in the adjuvant setting? No. But I think continuing pembro in that patient is reasonable, but I don't know that I'm looking to add a lot more toxic therapy in the adjuvant setting.
Absolutely, and similar to this case with microscopic residual disease, we had the discussion, but was not leading towards that, and in retrospect, glad we didn't, given the colitis that occurred. Yeah. Okay, we are at the end of this session, so I'd like to thank everybody for their questions and participation. We have a break next, so please do visit our exhibitors, and feel free, if you have additional questions, to come chat with us. Thank you.